I'm with Parrish. This is Jordan Rawson. We got UCL Sprain for our rehab project. So for our patient background, the patient is John. He's a 23-year-old collegiate baseball player. He's been pitching and playing baseball since he was about 10 years old. So he came to our clinic, referred from AT on 3/20/2017 with a slow onset of pain the morning after pitching a doubleheader. He doesn't remember a specific mechanism of injury, but within the same week, he was fully limited in his participation at practice due to pain and swelling. So he came to our clinic, like I said, reference from AT. Upon inspection, we diagnosed him with a grade 2 UCL sprain. So on the initial evaluation, the range of motion, he presented with pain 7 to 10 at the elbow, especially in greater than 60 degrees shoulder lateral rotation, so like the late cocking phase and early acceleration and throwing. He has pain whenever he makes a clenched fist, and we performed a valgus stress test that obviously presented pain and laxity in the joint. With his activities of daily living, he presents pain whenever he tries to open jars, turn door handles, washing the hair on the back of his head. We performed a manual muscle test. He's slightly limited in external and internal rotation, along with flexion at the shoulder with a grade of 4 or 5. He's also tender at the medial epicondyle of the elbow with palpation, and then swelling edema at the affected arm circumference of the distal humerus is 30 centimeters compared to the unaffected side, which is 25. So a little bit about the UCL. The UCL itself is a medial located structure. It has 3 bundles, the anterior, posterior, and transverse. These are based on the direction of the line of pull of the ligaments. It attaches from the medial epicondyle of the humerus to the coronoid process of the ulna, and it prevents excessive valgus motion. So with a grade 2 UCL sprain, a little bit about it. It's a minor tearing at the anterior bundle of the UCL, paired with very mild increase in laxity, joint space, and edema. This injury most of the time is caused by traumatic valgus stress during a fall with the arm outstretched, which could lead to UCL rupture. It's sometimes accompanied by elbow dislocation. Most often seen in baseball pitchers with the repetitive motion of throwing off-speed pitches. It could be in tennis players as well with hitting the rackets. The pain is usually along the medial epicondyle of the elbow, but it could be referred. So with obviously non-operative, operative interventions, with the non-operative, the beginning of the rehab is to get rid of the symptoms, manage the pain and inflammation, and increase range of motion. We usually start basic strengthening exercises from 3 to 4 weeks after the symptoms are completely gone. More advanced strengthening begins 6 to 7 weeks following the injury. So a throw-in program is usually involved in the later stages and is continued after return to play, most of the time accompanied with strict pitching limits. And obviously non-operative is going to be a lot shorter than operative. So with operative intervention, it's Tommy John surgery. Usually there's a graft replaced from a tendon elsewhere in the body or from a cadaver. So how they do the Tommy Johns, they usually drill holes in the bone and they put the tendon in there to help stability in a figure 8 motion at the medial elbow. So the main differences between post-op and non-op, obviously timing, but some of the different things, surgical incisions in the wound, so definitely that affects rehab and what we can do with the patient with strengthening and range of motion exercises. Subdermal, epidermal healing, obviously again the delayed pool access, you wouldn't want to get in the pool with an open wound. Manual therapy restrictions, and then as well as there's going to be, like I said, a longer rehab for operative.
Alright, so with our protocol, we broke it into 4 phases that we based off something that we learned a long time ago when we were PT students at Texas State. And the first couple of weeks was the acute series, so our goals here were to reduce the pain to touch from a 7 to 10 to a 4 to 10 by the 31st of March, as well as patient swelling. We tried to reduce that at the distal humerus by 2 centimeters by the 27th. Some modalities that we used were non-steroid anti-inflammatory drugs to really manage the inflammation period and not let it get out of hand, as well as rice to manage swelling and just give them a little pain relief with the cryotherapy. We also paired that with some light petrissage. This was manually moving all that lymph and swelling out of there, out of the region, so we could start working with that. Some exercises that we gave the patient were light elbow pumps from flexion to extension, as well as figure 8s. The patient would hold the shoulder out at 90 degrees and just move in a lateral figure 8. They started with the scapula stabilization from the top of the kinetic chain and just kind of stabilizes that whole system to begin strengthening. We also paired that with hand putty and wrist pumps, the same idea as those elbow pumps, to start moving the distal muscles and start working that out of there. So phase 2 was the beginning of light strengthening. Our goals here were to reduce the edema or return it to 25 centimeters if we can by the 27th, as well as reduce or eliminate the pain by the 27th as well. Some exercises that we did with those were wall push-ups to begin that valgus stress in the whole movement. You can do those in the pool to regress it a little bit to lighten the load, as well as hand grip resistance with springs. And then we also had the patient perform internal and external active range of motion at the shoulder. This just kind of, again, started the scapula and begins motion. We also paired that with resisted scapular pro and retraction, and weight bearing is tolerated upper extremity weight shifts on a table. This just introduced the idea of valgus stress to that tender ligament again. Here's a picture of that. So the phase 3 was from weeks 9 to 13. This is our goals here were to increase elbow flexion, manual muscle test to a 5 out of 5, completely restore that if we can, so we can get to more advanced strengthening later on, as well as internal and external range of motion, manual muscle test to a 5 out of 5 again, and eliminate the pain so we can move on to more advanced workouts. That was to be done by the 10th. Some exercises we did in this phase are tubing rows with a T-band, as well as tubing punches. These are kind of mirror workouts. So the tubing punches, we would hook up a T-band behind the patient and have them just punch straight out, side to side, switching arms. This just kind of works that whole kinetic chain all at once, gets the muscles moving, introduces more stresses to it, as well as dribbling down low. This gets some more valgus stress on that sites, as well as push-up planks, Supermans. Those all are pretty good. Just a picture of the T-band rows. So phase 4, from weeks 14 to 16, these are hopefully the last of our phases. And his goals here, he really wanted to be able to grip a ball and perform a throwing motion while that ball is still there, just to work that through the whole chain, and the ability to catch a ball and pitch it right back as if he's in the outfield. So that's getting really specific to his sport by the 20th for both. Exercises we did here are single hand rebounders, preferably in 90-degree shoulder abduction, as if he's actually throwing a ball. 30-foot slow pitch just to get the release out of there, and as well as pop fly catches. We can have the clinician drop a ball off the roof and have him catch that and kind of throw it back up if we need to simulate that, because we don't have a feel of that hand. As well as double-handed chest pass. This is to get the mirror images of his arms working together bilaterally, and so that introduces as well more valgus stress to that site from catching a ball. We can have it paired with a medicine ball to progress that, or just do air catches to regress it a little bit. So here's. In conclusion, the athlete, we hope, can return to play by 16 weeks with our protocol. We have him continuing a throwing program after that to further stabilize and strengthen the site. We don't want him to re-injure himself, and we don't want him to stress that all out again by going too hard. So we're really having the athletic trainers monitor him on their own time when he's out there. We want them to apply ice before and after every practice, just to really keep that system calm there, not aggravate it too much. As well, during the first 2 weeks, the patient is on strict pitch limits, preferably switching out with the other pitcher every other inning if they can, or just altogether limit the amount of pitches he's doing. So after that, he went to win the World Series, and we're very proud. He's going to get us some tickets one day, and I can't wait to go see him.